This project is titled Intermediate Health and Social Outcomes Following Participation in Hospital-Based Violence Intervention Programs. I'm Stephanie Bonney, and I'm the PI from this study from Rutgers New Jersey Medical School in Newark, New Jersey. One of the problems that HVIPs have faced in their research is that there's very little data to help us understand what is the best metric for evaluating what should be success. Typically, we've used recidivism, but recidivism can be subject to a number of ecological factors that may have nothing to do with whether or not the program is doing its intended work. This study will use a cohort study of hospitals that have HVIPs and hospitals that don't have HVIPs, and will enroll their victims of violence and follow patients at 3 and 6 months to evaluate whether or not they have improvement in early social and health outcomes. Things like getting victims of violence funding, school, jobs, mental health services, etc. The participants in the program will get surveys at 3 and 6 months, and they will be compensated for their participation.
My name is Luis da Luz. I am an assistant professor of surgery at the University of Toronto and a staff physician of the Department of Surgery at Sunnybrook Health Sciences Centre in Toronto, Canada. I would like to say thanks to EAST for electing my trial as one of the 2020 EAST multicenter trials. The first two trial will assess the early administration of concentrates of clotting factors for severely bleeding trauma patients in 8 level 1 trauma centers in Canada. Severely bleeding trauma patients may develop an early coagulopathy known as acute trauma coagulopathy. Bleeding coupled with this coagulopathy is the leading cause of in-hospital mortality in trauma. The acute trauma coagulopathy is multifactorial and characterized by an imbalance of the complex interplay in procoagulant, anticoagulant, and fibrinolytic pathways, and by platelet and endothelial dysfunction. Treatment of hemorrhage in trauma patients requires several steps that should happen in a coordinated fashion. The source of bleeding should be identified, and procedures should be adopted to minimize or stop the bleeding. Bleeding patients should be resuscitated via a massive hemorrhage protocol, usually with a fixed and balanced ratio, with a hemostatic component. Red blood cells, plasma, and platelets should be transfused respecting a ratio of 2:1:1 or 1:1:1. And to treat the acute trauma coagulopathy, replacement of clotting factors should happen. Until recently, clinicians were used to transfuse plasma, platelets, and cryoprecipitate to replace these clotting factors. However, recent evidence has demonstrated that prothrombin complex concentrate, a concentrate of the clotting factors 2, 7, 9, and 10, and fibrinogen concentrate, a purified human-derived concentrate of fibrinogen, have been used in trauma and other surgical settings, especially in European countries. Why we believe that the first two trials should be conducted? First, because the optimal method of resuscitation is not totally defined. There is also preliminary data that suggests that the use of both drugs reverses the acute trauma coagulopathy and decreases the volume of blood products transfused. In addition, safety and efficacy of using these drugs have not been assessed in a large randomized controlled trial. We believe that using both drugs in bleeding trauma patients, we will achieve a reduction of blood products transfusion, decreasing over-resuscitation. It may also reduce AB plasma transfusion and have the potential to restore these drugs in trauma rooms or extend their use in the pre-hospital setting, including austere environments. This will be a prospective, multi-center, randomized, parallel control, superiority, and pragmatic study comparing use of clotting factor concentrates with a standard massive hemorrhage protocol in severely bleeding trauma patients. We will include adult trauma patients who are bleeding and in whom a massive hemorrhage protocol is activated. Patients will be excluded if they have received more than 2 units of blood prior to the protocol activation, more than 3 hours post-injury, have penetrating brain injury with a Glasgow Coma scale of 3, have been using anticoagulants, are known to have a bleeding disorder, are pregnant, or refuse blood projects. The primary endpoint will be to demonstrate superiority with respect to the composite number of all allogenic blood products units transfused within 24 hours after admission. The secondary endpoint will be to demonstrate non-inferiority for the total number of RBC units transfused within 24 hours as surrogate for the degree of hemorrhage control. We will include also other exploratory endpoints such as clinical, laboratory, and safety endpoints as well. At the study flow graph, we see that the injury happens, patient is admitted to the trauma bay, the MHP is activated, the eligibility criteria is verified, and the patient is randomized. On the left side, the intervention group will receive 4 RBC units, 4 grams of FC, and 2,000 units of PCC. The second pack will contain 4 units of RBCs, plus both drugs, as in pack 1, added 1 dose of platelets, which corresponds to 4 units. From the third pack on, if the MHP is still active, the site will move to their local protocol, which will be a minimum of 2 to 1 to 1 ratio. On the opposite side, the control group, the first MHP pack will contain 4 RBC units, 4 units of plasma. The second pack will contain 4 RBC units, 4 units of plasma, and 1 dose of platelets. From the third pack on, if the MHP is still active, the pack will respect the minimum 2 to 1 to 1 in each site. When the MHP is terminated, the participating site will switch to a lab-guided transfusion or transfusion guided by a viscoelastic method, such as ROTEM, depending on each site standards. This trial will have an adaptive design. This is because the variability of the primary outcome is very large and the effect sizes are uncertain. So we will have a pilot phase enrolling 120 patients. We'll do an interim analysis to assess the power and sample size or other design modifications if needed, and then progress with patient enrollment. Thank you very much again. I'm happy to answer any questions through my email listed in this presentation.
My name is Eric Campion, and I'm the principal investigator on a new East multi-center trial, pre-hospital end-tidal carbon dioxide as a predictor of mortality and massive transfusion in trauma. Continuous end-tidal CO2 measurement has become ubiquitous across EMS agencies around the country. End-tidal CO2 measurement has been used to monitor both the quality of ventilation as well as, in many studies, the quality of CPR. We know that in critically injured patients, end-tidal CO2 decreases with decreased systemic perfusion. Patients in hemorrhagic shock can have a pronounced decrease in their end-tidal CO2 values. This has been utilized in studies in the operating room to demonstrate that lower levels of end-tidal CO2 are predictive of mortality in severely injured trauma patients. However, this phenomenon has not been thoroughly evaluated in the pre-hospital settings, with only a few studies investigating this, and all of these limited by small sample size, making adequate risk stratification quite difficult. To evaluate this, we're beginning a multi-center retrospective observational study. We're going to include all injured adult patients that are intubated prior to arrival in the emergency department from January 2017 through the end of December 2018. And we hypothesize that these pre-hospital end-tidal CO2 levels will be predictive of both massive transfusion and death. We will be collecting the typical demographic data, both injury and pre-hospital data, as well as serial pre-hospital end-tidal CO2 measurements and serial pre-hospital vitals. We anticipate chart review for this project will be relatively brief, with the records being reviewed of the pre-hospital run sheets, the emergency department records, and the initial operative records for the first 24 hours. All other data that will need to be collected should be readily available from the trauma registry at your facility. We'll be using the REDCap database to coordinate data collection between sites. Please consider joining our study and email me with any interest in joining the study or any questions, as well as our research assistant, Alexis Crowley, for any regulatory issues or questions as well. Thank you very much for considering our study.
Hello, my name is Zachary Mathey. I'm a surgery resident working with doctors Rachel Calcutt and Lucy Kornblith. trauma surgeons at the University of California, San Francisco. We would like to thank EAST and the Multi-Center Trials Committee for the opportunity to share our proposal entitled The Ultra Massive Transfusion Study, Defining Outcomes After Ultra Massive Transfusion in the Modern Era of Balanced and Goal-Directed Resuscitation. Hemorrhage remains a leading driver of early preventable deaths after injury. With the development of massive transfusion protocols and balanced resuscitation strategies, significant advances have been made. However, specifically for patients requiring ultramassive transfusion, mortality remains unacceptably high, ranging from 30 to 70% in the literature. While this is a relatively rare occurrence, we know these patients to be clinically complex, resource-intensive, and to occur across specialties. Prior research has aimed to develop predictive criteria for outcomes and futility, but this has proven challenging. Results have been inconclusive, and these studies have primarily been performed in eras prior to modern balanced and goal-directed resuscitation. Furthermore, only one study has reviewed ultramassive transfusion across specialties, but without granular enough data to perform predictive modeling for several important physiologic and clinical parameters. So there remains a need to better define predictors of outcomes in a modern era and across specialties. We anticipate identifying areas for further optimization of resuscitation strategies to validate or question existing practices and identify specialty differences. Our primary aim is to determine what clinical and physiologic parameters are predictive of outcomes in surgical and medical patients receiving ultramassive transfusion in a modern time period, and our secondary aim is to compare what clinical and physiologic parameters are predictive of outcomes in patients receiving ultramassive transfusion between our proposed historic and modern study periods. Because ultramassive transfusion is a relatively rare occurrence, we plan a multi-center retrospective cohort study. Our primary outcome is mortality, both early and late occurring, while our secondary outcomes are venous thromboembolism, multiple organ failure, and acute respiratory distress syndrome. We will include all patients who receive greater than 20 units of blood transfused in any 24-hour period, including all specialties from 2005 to 2019. Our only exclusion criteria are pediatric patients. Our strategy will be to identify these rare cases through review of blood bank records and other hospital-based registries, depending on each institution's record-keeping practices. Then, data collection will be performed, and REDCap will be used for safe, secure electronic data sharing. The IRB has been approved at UCSF, but will need to be approved at each center. Thank you so much for listening, and thank you again to EAST and the Multi-Center Trials Committee. If you're interested in participating, please do not hesitate to contact us. We look forward to hearing from you.
Hello, this is Chris Machete from Inova Fairfax Hospital, and this is an overview of the EAST Multi-Center Study, prospective comparison of a short versus long chest tube water seal trial for traumatic pneumothorax, known as the CT-PRO study. The study is a follow-up to a survey of EAST members about their chest tube management practices, which was published earlier this year. We found that surgeons' practices were highly variable. The duration of water seal trials used by EAST members varied from 4 to 24 hours. The CT-PRO study is a prospective study that will compare trauma centers that use a short water seal trial, 6 hours plus or minus 2, to those that use a long water seal trial of 24 hours plus or minus 2 hours. The study will be powered to show non-inferiority of a short trial compared to a long trial. Requirements are that the chest tube is put to suction after insertion, kept on suction for a minimum of 24 hours, and continued on suction until the water seal trial starts. Once water seal starts, it is expected that the chest tube will be removed if the trial is successful. We will also ask for 2 chest x-rays at specified times. Our primary outcomes are recurrent pneumothorax and failure of the water seal trial. Secondary outcomes include placement of a new tube on the same side, the duration of tube placement, number of chest x-rays, and hospital length of stay. We will include any adult patient with a pneumothorax due to trauma. It's okay if there's a hemothorax as well, as long as there is some pneumothorax. We're only including patients with one tube on each side, but it's okay to have bilateral single chest tubes, and it's okay to be on a ventilator. Exclusion criteria include all of the potential confounders, such as tubes placed during thoracic surgery, severe ARDS, bronchopleural fistula, etc. Our power analysis indicates that we'll need 1,325 total patients. If successful, this will be the largest prospective study of trauma chest tubes to date, so we really hope you will sign up. To sign up, go to the East website or email me or my research coordinator at the address shown. Thanks for listening, and we hope we will be working with you in the future.
Hello, and thank you for your interest in joining our efforts to understand and define safe management of wounds in the setting of damage control laparotomy. This project aims to determine the rate of superficial surgical site infections and surgical site occurrences after a closure of wounds with wicks or an incisional negative pressure device in patients that underwent damage control laparotomy. We also hope to determine if antibiotic irrigation decreases the incidence of superficial and overall surgical site infections after damage control laparotomy. This effort originated after noticing a broad range of wound management after abdominal closure following damage control laparotomy. This is likely due to lack of solid, evidence-based guidelines to aid in safe wound management. Our own institutional retrospective review for damage control laparotomy on 107 patients with class 3 or 4 wounds closed with wicks in place found 4 patients to have a surgical site infection and 14 a surgical site occurrence. Our data suggests that primary closure of incisions after damage control laparotomies is feasible, with acceptably low superficial surgical site infection rates. This study was designed as an observational study, where surgeons will treat their patients upon their own judgment. Therapeutic interventions of interest will be closure of wounds with placement of wicks or an incisional negative pressure device, as well as antibiotic irrigation prior to fascial closure. Data will be recorded using a simple tool, and a password-protected database will be used to record de-identified data for statistical analysis. It is our hope that the results of this study will provide the data necessary to convince surgeons that primary closure of more wounds after damage control laparotomy is feasible. We hope that this will lead to decreased healing time of these wounds, decreased overall cost of negative wound pressure therapy, and possible need for home health. Other complications such as hernia rates and enterocutaneous fistula rates might be also reduced in theory. Finally, patient satisfaction should be improved as well. We hope you will consider joining our efforts. For more information regarding this project, use the following email.
Hello, my name is Jordan Estroff. I'm an assistant professor at the George Washington University. I'd like to thank the East Multi-Institutional Trials Committee for allowing me to present our multi-institutional trial titled Use of Adnexin Alpha versus 4-Factor Prothrombin Complex Concentrate for the Reversal of Direct Oral Factor Xa Inhibitors. This retrospective review will evaluate for differences in outcomes following administration of Adnexin Alpha or 4-Factor PCC for the reversal of coagulopathy in trauma patients taking rivaroxaban or apixaban. Primary outcomes are quantity of packed red blood cells and fresh frozen plasma, or change in the Marshall score. I can be reached at jstroff@mfa.gwu.edu for additional questions. Thank you very much, and I look forward to hearing from you.
Greetings, potential co-investigators. Thank you for considering our study comparing operative versus non-operative treatment for complicated appendicitis with phlegmon or abscess. This is a prospective randomized study comparing patients with a likely perforated appendicitis by CT scan who have a phlegmon or abscess. Complicated appendicitis is a challenging problem for general and acute care surgeons and represents about 10% of acute appendicitis cases. Within the last 20 years, the management of complicated appendicitis has transitioned from surgery for all patients to non-operative management in cases where a significant abscess or phlegmon is present. This transition was likely driven by the use of CT scan for the diagnosis of complicated appendicitis. Surgeons began recommending non-operative management, likely for fear of the need for bowel resection to achieve source control. The risk for bowel resection, however, is very rare in acute appendicitis. There are, however, risks of percutaneous drainage, including erosion into the bowel requiring resection, renal injury, and vascular injury, among others. Recently, a single institution study from Finland demonstrated improved event-free recovery and reduced need for reintervention in the surgery group. The number of days hospitalized was slightly shorter, though not statistically better in the surgery group. Almost one-third of patients in the non-operative arm required an unplanned surgery or an additional intervention, while almost half required repeat CT scanning compared to only 10% of surgical patients. We are proposing a prospective, randomized clinical trial to confirm the findings of the Finnish study in the U.S. population. We will include all patients who have perforated appendicitis with abscess of at least 2 centimeters or phlegmon of at least 4 centimeters. The exclusions are also listed here. We plan to randomize patients within 24 hours of diagnosis of perforated appendicitis with phlegmon or abscess. We would expect most patients to be initially planned for non-operative management, and they will be the focus of our study. We hope that once the study becomes known, more patients will be referred for randomization. Patients will be randomized to laparoscopic appendectomy or ongoing non-operative management. We have 2 primary outcomes. First is the number of hospital-free days in the 60 days following randomization, and the second is the need for additional interventions after primary intervention, which in the case of phlegmon may be simply antibiotic therapy. The secondary outcomes are also listed. For analysis, we will pursue both intention to treat and a per-protocol analysis. We'll use standard statistical tests and have a priori defined 2 subgroups, those over 70 years old and those with abscesses greater than 5 centimeters. It is our goal to enroll 180 patients across all centers in this study to demonstrate 1 additional hospital-free day. I, of course, welcome any questions or comments. Thank you.
Currently, there are no evidence-based guidelines for management for traumatic grade 1 or 2 splenic injuries with active extravasation on CT scan. Previous studies that have demonstrated high failure rates of observation in patients with active extravasation and splenic injuries have been in patients with splenic injuries of grade 3 or higher. Embolization of all patients with low-grade splenic injuries with active extravasation could lead to immunologic insufficiency without benefit. The purpose of this study is to determine the incidence of medical management failure of grade 1 and 2 splenic injuries with active contrast extravasation in the hemodynamically stable patient. Because the incidence of grade 1 or 2 splenic injuries with active extravasation is low, we are recruiting institutions to participate in a retrospective observational study to determine the failure rate of observation in these patients with low-grade splenic injuries and active extravasation. The inclusion criteria include patients 18 years of age or older, grade 1 or 2 splenic injuries secondary to trauma with active contrast extravasation on CT scan. Exclusion criteria include hemodynamic instability and patients on anticoagulant or antiplatelet therapy. Our primary outcome will be failure of medical management requiring angioembolization or surgical intervention. The secondary outcomes that we will be evaluating in our study are mortality, length of stay, ICU length of stay, and transfusion requirements. If you wish to participate in this study, please go to the East Multi-Center Trial homepage and fill out the online center sign-up form.